Finally, if we really believe in choices for patients, and we want to let parents be parents, which is what I want to do, I want to give people choices, real choices. 20% of people don't want to do an abortion or terminate no matter what. In fact, I'll show you some other data that says it's probably higher than that. It's 75 to 85% of people don't want to do termination of pregnancy. They want to take care of their children. They want to take care of their babies. Maternal mortality, we talked about that. We're worried about moms dying because of having these babies go on. Well, if you look at abortions past about 16 to 20 weeks, which is kind of the time you do most of these terminations for anomalies, the data is very similar. If you believe maternal mortality data, which if you ever want to talk about that sometime, we can talk about that. But it's exactly the same. There's no difference. Okay, so you're not going to have more moms die because you let them be pregnant longer, right? This is my lovely commercial wife, Catherine, as I call her, and she allows me to do all those things, and that's why I always like to show pictures of her. What about hospice? I'm sure you've all heard a little bit about this, or maybe had somebody who's gone through hospice, or know about somebody who's gone through hospice, or has had a family member go through hospice. Very common. Cecily Saunders. Anybody know about Cecily Saunders at all? It's fascinating. A wonderful English woman. Anybody know who Cecily was when she first started out in life? She was a social worker. Who then went to nursing school. And as a social worker, when you know what she saw people doing, people were dying were put in rooms and left alone to die. They weren't dead, but they were treated as they were dead. Right? I'm not dead yet, but yes, you are dead. You know what you're talking about when you're not. And she said the real issue was withdrawal from the patient by the family and staff and physicians. If you talk to people that are going through hospice, they fear withdrawal more than they'll fear pain. They're not dead. They don't want to treat like they're dead. That's what she did and helped us do. So what we're doing now is trying to provide a framework to help patients work through a fatal anomaly in a hospice concept. I'm going to ask another very important question, and this is going to sound terrible later. Anybody think about life here? Oh, I didn't think so. It's not a matter of if, is it? It's a matter of when. It's a matter of when, isn't it? I'm glad you didn't answer that because I got a little worried. We didn't have some of your psychology or psychiatric people out there. What about, why do we have to go to the perinatal concept? Well, if you're in peds yet, peds rotation that much? No? Well, I hope you don't have this fortune. I don't mean that in a bad way. I did mine on Toomer West. It was at the University of Iowa. We have one of the biggest oncology programs in the university at that time in Iowa, Michigan. Don't hold against me. But I spent 6 weeks treating tumors and cancers, right? And watching kids die. That was no fun, trust me. Most of the clinical depression I've faced in my life. But that's where we got the neonatal, we learned the pediatric hospice concepts. But what do you do if the baby is not born yet? It's not there, right? There's no neonatal there. So that doesn't really work, does it? Now the concepts work, but that doesn't really work for us. Oh, isn't she cute? This is Penelope. This is Penelope. She has really bright red hair, she really does. And I saw her outside, she's just so cute. She's like 8 months old now. And the good part about being the parents having grandchildren, because you get to send them home, right? They're bad, you send them home. Well, so what is perinatal hospice? I call it the prenatal diagnosis of a terminally ill fetus in utero leading to perinatal hospice as part of the continuation or the continuum of end-of-life care. Okay? So it's okay to take care of you and do that after born like you do before you're born. Let's help these parents be parents. Let's give them a choice. Let's help them through this. Well, what are the characteristics of perinatal hospice? It's extremely comprehensive. It starts in my office when I diagnose it, or the obstetrician's office when they diagnose it, or the family medicine doctor can do an ultrasound, or the sonographer comes in and says, Dr. Calvin, I think we got an ancestry. I see that all the time. Last week, walk in, 14 weeks, ancestry. And that's supposed to be the happy, normal ultrasound. Not so happy and normal now. So, emotional needs of these patients, many of them are people of faith, so we try to meet the spiritual needs. Psychosocial, I have a very, very low income population. Some of them can't even make their appointments. How do I get them to see me? You gotta have that. Medical and obstetrical needs, which is what I can do with my sonographers. I have residents. I have 3 residents a year, 12 here, 12 and 12 total. So for those who are interested in obstetrics and gynecology, I'm on your here. If you're interested in coming to the program, take a look at it, feel free. All the contact information, always glad to have students. Even 4th-year students rotation if you want. Come through the NFM and see how we do it. It's multidisciplinary. In other words, I involve nursing, sonographers, social services, chaplain services, my neonatologists, labor delivery nurses, neonatal nurses, all are involved in our process at some point in this time frame. We also involve other family members. If grandparents want to come in, other people want to come in, we're glad to have them talk to them. And it's coordinated. That's probably the most important part of this, is you don't stow population at the coordinated care. Well, how do we do this? We're going to talk about that in just a second. I have 2 published series of about 70 patients, since you don't see these every day, actually, which are probably the largest series of published outcomes in the world so far together. And 70-80% of people will do this if you offer to. You give a real choice, right? I only use terminally ill babies in this. I use chromosomes and anatomy surveys. I use MSCs to confirm that I have a family mountain of some sort. Okay? Again, my focus is always in this on patient. It's not about you at that point, and it really never is. You're in sheriff deciding, okay, let's do this. It's really not about you. And your moms and dads have told you that. Everybody else has told you that. It's really not about you. It's about your patient. And if you don't like that, I suggest you get out of medicine and all sincere. Because nobody cares about your 9 to 4. Nobody cares about your personal problem. Nobody cares about your lifestyle. They care that you're taken care of. I mean that sincerely. Doesn't mean you don't bring stuff to the table. You are, and your passion, and your love for people. But it's about your patient. And that's what this is really about. My whole thing is to support the patients, to reassure them, and provide them an alternative. These are the few patients that get my personal cell phone, which I don't give out to everybody. Unlike you, I don't really want to talk to people. I'm sorry. I don't tweet, I don't Twitter, I don't mail. I don't Facebook. I'm not very social, I love it. This is my second child. This is my handicapped daughter. This is Floppy Faith, as I call her. And if you knew Faith, you would think she was handicapped. But the handicap would be you, not her. Because she would work you to get what she wanted to do. Because she would get around, but she'd make you think she couldn't. And she'd actually get into something you didn't want her to, because she'd want to do that. She's a very entertaining, loving child, but she looks handicapped. Well, who do I have? I have a lot of people because I never got into something like this, and I'm very, very blessed in that respect. I'm very, very fortunate. I have good residents, I have wonderful sonographers, I have great nurses, social services, and chaplains, and all these people are really helping me do this. This is not something you do in a vacuum. It's like most complicated care. It's like taking care of a really bad diabetic, or a bad cardiac patient, or a bad pulmonary patient, or a badly addicted patient. You need a really good team. And you need to want to do it. Again, if you don't want to, don't. Send them to me or send them to somebody who wants to do this. Well, how do I do it? And I'm a little military guy, so I like a little diagram. Okay, cool. Okay. A little arrows. Well, basically, if you want to do, as a patient, you want to do anything about IV or feed or surgeries to close defects, whatever you want to, pain, medicines, IVs, and stuff, you can do that in my world. Okay? We'll do what you want to do. And it's very important for the patients to understand that we are not caring for their patient or their child. We're doing a lot of things for them. It's just not going to end up with their child going home necessarily. So we can do a lot, both anticipatory and during the time of birth, and shortly after birth. That's Mercy now, the little embryo you saw, the little fetus. She's now 16, and we're in front of the UN. We're for the 50th anniversary of signing the charter. She's an Appalachian Children's Choir. And so we're there singing. Of course, I'm chaplain because that's what that's here, right? I think she's got it lovely. Of course, I'm biased. Well, what about the outcomes? Well, I did 2 different papers, and I put them together to kind of show you what I found. What I found is that about 80% of my 2 group chose to carry their babies, right? 20% chose to terminate. Out of that, we had a stillbirth rate of about 30%, which is very interesting. So what's fascinating about this is that you didn't have to do anything to anybody for 30%, right? It was a totally unnecessary procedure that you did to somebody. You terminated the pregnancy when you didn't have to. The natural history of the disease itself would end it, and you wouldn't have to do it. Because remember what happens to people when you terminate, they don't do all psychologically, right? They want that baby. So just think that through. So you don't have to do it. Live born about 67% or 33 out of 49. We did cesarean sections. Of course, everybody does. Why would you cesarean section on anesthetic? Good question, isn't it? Well, it's about autonomy and choices. And you can have a cesarean section. Did you know that young ladies can have a cesarean section just because you want it? That's what ACOG says. Now, I'm not going to do that, mind you, because I don't want to kill you, but ACOG says you can. So if you can do it because you want to, just because, right? I want to have it on my granddad's birthday, or I want, no, really, this is the truth. I'm not lying about this. ACOG says you can do whatever you want. Why can't they have their baby by cesarean section that's going to die so they can baptize or spend time with it or have time with the children and other family members with it? Is there a problem with that as long as they understand the risk of that? I think not. So I don't have a problem with that. As long as they're informed, right? So I did actually 33 in Madigan. I had 85% achieving hospice. And I had 61% live birth. That was when I was in the military. And I had 5 of my 28 were cesarean sections. And I just want to point out that these were babies that really weren't going to live, right? I had an ventral dysplasia, which is, of course, the fatal organism. They all died from restricted pulmonary disorder. I had a baby with a large posterior encephalocele, where basically the whole brain was out. I had a baby with leukodysgenesis and hyperamios. I had a kid with renalogenesis, and then I had a leukoskeletal dysplasia of the encephalocele. And all those were liveborns, and all of them got to spend time with their mothers and fathers and siblings that were there, and were baptized or had some sort of a ceremony that the family wanted. And that's extremely important to them. Because remember, it's about them, it's not about them. Where is my daughter Mercy? I'll give you a hint, it's in Rome. It's in St. Peter's Square. That's St. Peter's Basilica. She's standing in front of that. My daughter's a world traveler because, of course, everywhere I go, she has to go, right? I don't know about you, young ladies, my daughter's like, she looks in this town, that's how I go. It's true. Well, then I did it in the civilian world because in the military, you did abortions, right? In the civilian world, you can do whatever you wanted to do. And really interestingly enough, I had almost the same number of patients, about 76% of the 21 that I got, actually 75% chose hospice. So it's very interesting to note that if you gave people options, they actually gravitated toward this hospice care, this care for their babies, these one parents, right? They want to take care of their baby. Again, live boards are about 76%. I had 24%, or 5 of them were IUFTs, only one cesarean section by request at that point, right? Does anybody know what this is? I'm sorry, just give me a world tour here. I don't want you to get bored. I hate being bored. Where is this? Anybody know? It's in Portugal. It's a very famous site. There were some shepherd boys. Fatima. This is Fatima. And went to Portugal in a meeting, and you're not a big pilgrimage guy, right? It's not me. So we're going to say, let's just go see Fatima. So we go there, and this is a setting that's not really like this picture. Probably one picture I did that turned out actually. It was absolutely luminescent. It's the most beautiful thing I've ever seen in the setting sun. This beautiful cathedral. It was just spectacular. You just thought, wow, I'd like to go back to Portugal. Great wine, chocolate, yeah. Well, what about our experience? We had about 20 minutes. We had one trisomy 18 baby, which is not truly lethal, but then you had a cardiac anomaly. You thought it would expire shortly after birth, and actually lived about 256, almost a year. And if you look at the trisomy 13, 18 data, those babies are living longer and longer with better care. So stay tuned on that. It's not really a lethal anomaly. All of my families really appreciate the opportunity to spend time with their infants. Most of them were glad they had time to baptize or spend time with their children. There were also opportunities for funerals and memorials, which is a lot of time determinations we necessarily have. We did not have any maternal mortality or morbidities. In other words, my infection rates weren't higher. It was a small study, right? So we didn't have any of that stuff happen to us. We also got through autopsies because about 20% of the time you have a diagnosis and made a change by an autopsy. If you do destructive procedures to babies, you can't put them back together. It's very difficult, right, to reassemble. Yeah. Well, I think the biggest thing that my families really did, and this is the way it really sort of helps us all out, it transforms labor and delivery, it transforms the whole process. Because now people are saying, we have another way of doing this. Because most people I know really don't like the idea of having to terminate pregnancies, even for anomalies, and don't like the fact that you're going to abandon the patient, you're going to tell them to leave your office and not, don't come back, which I've heard before actually. Not maybe some people. They're sent out of the office and just told to not come back. And I find that to be very interesting. So they come to me instead, which is fine. I'm glad to